Welcome everyone, and thank you for joining us for the Long COVID Support for Healthcare Professionals webinar. I'm Govindra, I'm the Digital Engagement and Comms Officer for HCSA. We're presenting this webinar as part of our Wellbeing Programme. This is a series which is led by experts, which is aimed at all healthcare professionals. We're really pleased to be able to host tonight's event on such an important topic, which is long COVID. Throughout the COVID pandemic, many healthcare professionals have been seriously affected by occupational exposure to COVID while providing essential care to patients. These healthcare professionals do face loss of career, employment and income, and all alongside the effects of the illness itself. Meanwhile, adequate protection at work for healthcare professionals are still not in place. The aim of this webinar is to explore what support is available, how it can be accessed, and what changes are needed to better protect people at work. We're joined today by Dr. Sean Keshi to tackle those questions and much more. Before I let Dr. Keshi introduce himself, I just want to go through some housekeeping rules just to make everyone aware that this webinar is being recorded and it will be available publicly to view on our YouTube channel. If you do have any questions, can you please use the Q&A function on your screen, and what we'll do towards the end of the presentation, we will go through those questions. You have the option to either ask the question yourself, well, we can unmute you, or if you'd like to remain anonymous, then we can ask the question for you. Please feel free to use the chat throughout the presentations for any questions. And we have my colleague here, Joanne, who's going to be monitoring that. This is a safe and respectful environment, so please contribute if you feel comfortable to, but there's no pressure if you don't want to. And also, we'd just like to make you aware that we won't be able to answer any personal clinical questions that you have, but would advise, of course, that you seek the advice of a doctor and to check the resources that we will signpost you to at the end of the webinar for any work-related, if you have any work-related issues, then please reach out to your trade union. HCSA members can access expert advice for our helpline, either by email or the member portal, and we'll put the details in the chat. If you're not a hospital doctor or you're not a member of HCSA, we are the only professional association and trade union focused solely on hospital doctors, wherever you are in your career. So if you would like to join us to become a member, we'll put the link in the chat, and it's hcsa.com/join. So what I'd like to do, I'd like to hand over to Dr. Sean Peter Keshi, who will be leading on this presentation. We had some technical issues, so you will be able to hear Sean, but not be able to see him. So please, let me hand over to Sean.
That's great, thank you. And just to check, can you see my slides there?
Yes, we can.
Yeah, brilliant. So thank you very much for the introduction, Gurvinda. I'm very pleased to be with you this evening. As we've said, although you can't see me on webcam due to some technical difficulties, I am here and pleased to be. So I am Sean Keshi. I am a palliative care doctor here in Scotland, and also a person living with long COVID. I developed COVID through occupational exposure during the first wave of the pandemic, and unfortunately have developed a number of chronic complications as a result of that. Since then, I have been very active as I've been able in advocacy related to kind of justice for healthcare workers who are affected by long COVID, as well as better protections in the workplace. I'm going to be talking to you for the next half an hour or so about long COVID, with a focus on support for healthcare professionals who are affected, starting off with a little bit of information about COVID-19 and the mode of transmission, because that's so fundamental to the rest of the presentation and what we're going to be talking about, what protections are needed from COVID-19 and were indeed missing, which has led to the devastating effects on the healthcare workforce and the amount of disability, i.e. long COVID. Then we'll talk about what changes we need to see and the support that's needed and can be offered. So that includes supporting others, your colleagues who are affected, or what support may be possible for you if you are personally affected. And I'm hoping that we'll have a good discussion at the end. So do please put your questions in the chat as we go along. As Govinda has said, I'm not in a position to give you medical advice. And also I'm not really able to go into detail about giving advice about people's individual specific problems that they may be having with work, but we will be discussing these issues in a more general way. So to begin with, COVID-19, as we know, is a complex disease caused by the virus SARS-CoV-2, which has caused millions of deaths throughout the world, including over 220,000 deaths in the UK. But the number of deaths is only the tip of the iceberg of the damage which has been caused and is being caused by COVID. And we know that many more people are affected by disability. SARS-CoV-2 is a biological hazard which is spread by airborne transmission. And even though many of us have been told by our employers that SARS-2 is only airborne in specific circumstances, i.e. when aerosol generating procedures are carried out, such as intubation, this is not true. And there is unanimous scientific consensus among experts that SARS-CoV-2 is unequivocally airborne. It's airborne all the time. I mean, not only is this obvious because the original SARS is agreed to be airborne, other coronaviruses like MERS are airborne. And it should be obvious looking at the way that COVID has spread throughout the world like wildfire, throughout countries, throughout cruise ships, hotels, hospitals, care homes, that it is spread by tiny aerosols which are suspended and remain airborne in environments. There is also indeed scientific evidence of this specifically, that coughing, speaking, and breathing generate COVID-containing aerosols. And in fact, coughing can generate more aerosols than so-called aerosol-generating procedures, such as intubation. So with that in mind, we have to consider the protections that are necessary from COVID-19. Well, healthcare workers are at risk, 3 to 4 times more likely to contract SARS-CoV-2 than the general population, and 7 times more likely to have severe COVID. So with this risk and protection to mitigate this, protective measures clearly must protect against an airborne hazard. And as a reminder, across industry and other occupational groups, this is the level of protection which is given to workers working with airborne hazards. And you may have seen this image that was on my first slide of this healthcare worker wearing a respirator. And actually, this looks like it probably is an appropriate level of respiratory protection from inhaling airborne hazards in the workplace, such as SARS-CoV-2. But unfortunately, most of us were not provided with this level of protection. We were told to wash our hands and to wear flimsy blue surgical masks. So it should be obvious that, you could, if you were to go into a room filled with smoke, wearing a blue surgical mask is not going to do much to prevent you inhaling the noxious particles in that room. Or if you were to go into any other industry where there's airborne hazards in that environment, a surgical mask is not going to offer sufficient protection from you inhaling the aerosols in that environment. And hand washing is an important thing to do generally for reducing the risk of other organisms being spread, but you could wash your hands for 50 years and that would not protect you from catching COVID. In fact, the Health and Safety Executive itself has said from well before the COVID pandemic started that while surgical masks will provide a physical barrier to large projected droplets, they do not provide full respiratory protection against smaller suspended droplets and aerosols. That is, they're not regarded as personal protective equipment under the European directive. This is not new, the idea that diseases are airborne. In fact, one of the great healthcare visionaries of the last 200 years, Florence Nightingale, wrote in 1858, "Infection acts through the air, poison the air breathed by individuals, and there is infection. Sick people are more susceptible than healthy people, and if they be shut up without sufficient space and sufficient fresh air, there will be produced the usual tribe of hospital-generated epidemic diseases." So it's very apt and accurate from Florence Nightingale, but something has gone badly wrong between 1858 and 2020, when our system's way of managing diseases in hospital has become, frankly, stupid. And if we look at lessons from even much more recently, thinking back to earlier on in the 21st century with the original SARS infectious outbreak, what was found in the inquiries that were held after that was that the important precautionary principle was not followed in those outbreaks. The precautionary principle being, where there is reasonable evidence of an impending threat to public health, it is inappropriate to require proof of causation beyond a reasonable doubt before taking steps to avert that threat. In Canada, where there were a number of patients and healthcare workers affected in a healthcare-associated outbreak of SARS-1, found through their commission in 2006. One example was the debate over whether SARS was transmitted by large droplets or through airborne particles. The point is not who was right and who was wrong in the debate. When it comes to worker safety in hospitals, we should be driven by the precautionary principle that reasonable steps to reduce risk should not await scientific certainty. In other words, the high appropriate level of precaution should be put in place even if there is not certainty. You should not be using the lowest level of precaution that you can get away with and just think that's probably going to be okay because you're still waiting for proof that this hazard is airborne. And it's very sad to think that, especially as the original SARS was considered to be our dress rehearsal for how we would cope with future infectious outbreaks, it's sad to think how much death and destruction could potentially have been prevented if the lessons from the SARS outbreak had been taken to heart. So with those things in mind, we have to consider what protections are necessary from COVID-19. We need a combination of engineering controls, so that involves infrastructural changes like ventilation and filtration, and control at the source of infection, such as masking and physical distancing. So in terms of engineering controls, well, unfortunately, the vast majority of our buildings, including hospitals, only have the bare minimum ventilation. And we need to improve ventilation and filtration of air in order to reduce the spread of COVID and other airborne hazards. And there is evidence that high efficiency particulate air filters, HEPA filters, reduce the risk of nosocomial infection with COVID. The Lancet COVID-19 Commission task force recommends that there should be non-infectious air delivery rates of at least 4 to 6 equivalent air changes per hour, but greater than 6 would be best practice. And in high-risk environments, this increases to 12 to 20 air changes per hour. So there's a big gap between the current level of ventilation in hospitals and what is recommended as best practice. Unfortunately for us, though, as we think about these issues and what we can do as individuals, yes, we should be supporting infrastructure changes that would improve ventilation and filtration, but actually what we think about when we do what we can achieve on a day-to-day basis, that is more in keeping with the source controls, such as appropriate use of PPE. This is something that should be more achievable for us. So as we've spoken about, we need respiratory protective equipment. That is PPE, which is designed specifically to protect the respiratory system from inhalation of airborne hazards. And practically, this means at least FFP2 and preferably FFP3 respirators, which are shown to reduce occupational exposure of SARS to healthcare workers and reduce the risk of transmission to patients. And we've seen ourselves throughout the pandemic that the few staff in settings like critical care who did have access to FFP3 respirators were less likely to get sick from occupationally acquired COVID compared to staff in other areas, the rest of us who did not have this access. And when we speak about these protections, I'm not just saying that, oh, it would be nice for your employer to do these things, they'd be doing you a favor if they did this. No, that's not the case. This is the law. It is well enshrined in law that your employer has a duty of care to look after employees, and they have to carry out risk assessments and do take necessary reasonable steps to reduce your exposure to dangerous hazards. In fact, Employment Rights Act gives you the right to withdraw from a workplace without discipline under Section 44 if you consider your workplace to be unsafe until it is made safe again. And we should also be aware that UK law supersedes anything else which is not law. So the government can produce quote unquote PPE guidelines. Your employer can just disseminate pieces of paper which tell you that you just need to wash your hands and wear surgical masks. But those are all trumped by the law. It's not your employer's job to make sure that they're following any guidance which is contrary to the law. It's your employer's job to follow the law. And we're going to be focusing mainly on the disability that's been caused by COVID to healthcare workers. But we have to acknowledge that, firstly, the number of deaths there have been among healthcare workers, at least 180,000. And that figure's from 2021, so presumably there's many more by now. And in the UK, the official figure is 2,100 health and social care worker deaths. However, this is clearly a gross underestimate because every time an employee develops occupational illness, including COVID, and particularly if they die from an occupational illness, the employer is supposed to report that through RIDDOR reporting to the Health and Safety Executive. However, there's been a great dearth of RIDDOR reports being submitted to the Health and Safety Executive in this area, with many NHS trusts claiming that no healthcare workers at all in their trust have died from COVID, which I find an extraordinary claim. And it does lead me to believe that the number of people who die, health and social care workers in the UK who have died from COVID is greater than 2,100. And I don't believe that we'll ever know the real number. And again, it's very sad to think about our colleagues who went to work to try to serve the community throughout the pandemic, providing much needed medical care, and have died as a result of that. Nobody goes to work to die. And we don't have time to go into the epidemiology of COVID, but it's we do have to be conscious that we're not just talking about a problem of the past. This is not a problem that was just self-contained between 2020 and 2022. As of right now, there are at least 750,000 people living in the UK who currently have COVID-19. And we do have other circulating hazardous airborne agents like measles, and we will be having future pandemics as well. And just in the past few weeks, there has been a case of a medical ward in Scotland, a Scottish hospital, having to close due to a COVID outbreak. So now let's move on to focusing on long COVID. So I personally think that a more accurate way of a more accurate term is post-acute COVID syndrome. But in any case, we're talking about an umbrella term for a syndrome that continues or develops as a probable result of COVID-19. And there's different definitions for it. For example, the World Health Organization talks about usually developing within 3 months. NICE differentiates between ongoing symptomatic COVID and post-COVID syndrome, but talks about a 4-week cutoff for gauging something as being long COVID. I don't really think it matters for the purposes of the presentation, as long as you understand that I'm talking about a situation where someone has developed chronic complications, chronic health problems as a result of COVID-19. We're not just talking about someone who had a nasty virus and is just taking a while to get their energy back, and then once it's back, they're back to normal. We're talking about someone who had a virus and has now got a chronic health condition. So long COVID occurs in 10% of those infected, but the situation gets much worse with reinfections, with that number increasing to approximately 20%, and reinfections also increasing the risk of hospitalization, death, cardiac disease, thromboembolic disease, and neurological and lung damage, among other things. And despite how prevalent long COVID is nowadays, and the number of very life-changing symptoms it can cause, people with long COVID are struggling to obtain comprehensive medical assessments and the medical care that they need. There's a huge variation in the number of symptoms, the way it can manifest, but commonly can encompass weakness, malaise, fatigue, pain, breathlessness, problems with concentration and memory, autonomic nervous system dysfunction, immune changes, and really damage to every body system is possible. I don't believe that that there is a system of the body which hasn't been reported to be damaged by COVID so far. Long COVID has a very uncertain prognosis, and there is no known cure. I did want to just focus a little bit on chronic fatigue, just to mention that although there may be a tendency, certainly among doctors, to think about people who have very specific organ damage, like myocarditis, for example, as a result of COVID, as being kind of having more validity compared to other patients whose predominant limiting symptom is fatigue. But I think it's very important to acknowledge that fatigue and long COVID is an absolutely devastating symptom. And what we're talking about in many cases is actually a syndrome known as post-exertional symptom exacerbation, whereby patients have very limited energy. They're fatigued all the time, but if they exceed a very limited window of energy, then all their symptoms get worse, and they have what we call a crash, which it can make their whole condition deteriorate. So this is incredibly limiting. And this is also, I mean, that limitation, the effects that this has on quality of life are substantiated by research, with functional impairment worse than stroke, comparable to Parkinson's disease, and health-related quality of life worse than many patients with advanced metastatic cancer. And we should know this already from another condition where this syndrome, post-exertional symptom exacerbation, occurs, ME/CFS, which also is commonly brought on by infections. And similarly, the patients with ME have very poor quality of life. For example, find to have a poor quality of life compared to patients with multiple sclerosis. So we definitely should never be thinking, oh, that patient's just got fatigue. Fatigue in post-infectious syndromes like long COVID is an absolutely disabling and life-changing symptom. So long COVID has affected probably more than 100,000 healthcare workers in the UK. Is contributing to the NHS staffing crisis. And despite the fact that most healthcare workers who are infected or who are affected as a result of occupational exposure to COVID, they have themselves received limited care and assessment in seeking help for their situation. NHS employees who were employed directly by the NHS were protected under a COVID special leave arrangement until summer of 2022, when the 4 nations of the UK withdrew those protections and put employees onto normal sick leave arrangements, which has also opened up the door for starting absence procedures, people being released from their jobs. And we're now seeing healthcare workers losing their employment, losing their career, being rendered financially destitute, even losing houses. And the further that we get away from the protections of COVID special leave, it's looking likely that range of damage to people's lives is going to increase. So we need to change now, not only for those who are already affected, but also acknowledging that the pandemic is not over and the risks of COVID-19 continue, and vaccination does, even though it may slightly reduce your risk of COVID-19, of long COVID, if you're infected, you are still at significant risk of long COVID, even if you're vaccinated. So this is not a problem of yesterday, as we've said. This is an ongoing problem that everyone should take seriously. So what changes do we need? Well, we need high quality research into long COVID, and linked to that, we need treatments for people with long COVID. So I'm not going to go into a lot of detail about that, but I think ultimately people with long COVID want to get better. And as we've said, people who've been affected by long COVID have been left without medical help in this situation where they're disabled, want to get back to the life that they had. So what we really do need as a component of how we're going to fix this crisis is treatment for people who are affected. So as an adjacent to, as an adjunct to what we're going to talk about in the rest of the presentation, we have to be conscious that the research and the treatment is very much what we as a society should be pushing for as well. So we also need prevention of getting COVID in the first place or getting reinfected with COVID. And this is needed for the welfare of patients, service users, and staff. So this encompasses, as we've spoken about, robust PPE in the workplace, respiratory protective equipment and engineering controls, ventilation and air filtration. We also need action to be taken. So we can't just we can't just be passive in the face of all these the number of people who've been affected and being rendered destitute as a result of this. So one means of recourse or means of providing welfare and stability to people who are financially impacted by long COVID would potentially be through industrial injuries, disablement benefits. However, so far, long COVID is not a prescribed illness as an occupational injury under this scheme. However, the Industrial Injury Advisory Council has, towards the end of 2022, recommended 5 very specific complications of COVID for prescription as occupational injury, which would hopefully lead to people with those specific complications being eligible for receiving that benefit. However, they have not so far recommended long COVID or post-COVID syndrome itself because they do not so far consider the evidence or the ability to diagnose the syndrome to be precise and measurable enough. There are other people who are working towards support, including financial support for affected people. So the Key Worker Petition UK campaign have gathered several thousand signatures, which they've submitted to the UK government, campaigning for pension and compensation scheme for all affected key workers, not just healthcare workers. There's also advocacy ongoing about having better protections in place in the workplace to protect patients and staff. So, for example, a group that I have co-founded for representation in the Scottish COVID inquiry, the Scottish Healthcare Workers Coalition, we have submitted an open letter recently to the Scottish Government demanding better PPE and ventilation and filtration in Scottish hospitals and care homes. We need the COVID inquiries throughout the UK to examine the details, examine the evidence and what was known, things like the Canadian SARS Commission and what counts and what doesn't count as PPE. We need all those all the evidence laid out and examined by the inquiries in a formal way. And we're hopeful that having that all out in the open and seeing the many flaws that have happened across the way and the failure there's been to protect patients and healthcare workers will open the door for future means of recourse and future means of recourse. And there are also charities at work. So, for example, Supporting Healthcare Heroes is a charity which has been set up, which aims to provide financial help, financial grants to healthcare workers who've been affected by long COVID. So move on to speak a bit more specifically about support. As we move forward, I should emphasize that I am not an employment advisor, but we'll speak about these issues in a kind of general way from what I've learned as a healthcare worker with long COVID, who has had a very steep learning curve over the last few years about these issues. And the first thing to say is that, as I've tried to emphasize, people living with long COVID need comprehensive medical assessment and treatment. So I'm sure that's out with the scope of what I'm going to be talking about today, but what we say going forward does not mean to undermine that ultimately patients with long COVID need treatment, but just with the acknowledgement that people are struggling to get the assessment and treatment that they need at the moment. Within that framework, we'll think about what support might be a good idea or may be available. So firstly, if you are not personally affected, but you're thinking about how you might support a colleague who is affected, I think actually one of the very most important things you can do is to believe your colleague. People with long COVID have gone through a lot of gaslighting in many cases, and actually, you might not understand what it's like to have those symptoms, but you can try your best to educate yourself about the fluctuating nature of long COVID, including understanding post-exertional symptom exacerbation. People are not just a bit tired, they can't just push through. They actually need to pace themselves in order to maintain the level, whatever level of health they have, and not get any worse. Also, don't be complacent and remember the responsibilities that you have towards patients and your colleagues, and anything that you can do to use appropriate PPE and not spread COVID to other people. Remember that, as we've said, infections and reinfections are dangerous, and don't feel reassured just because you've had COVID before and you recovered fully that long COVID won't happen to you in the future. I personally know a doctor who had COVID 3 times before they developed long COVID, despite the fact that they recovered fully the first 2 times they had COVID, but the 3rd time has resulted in very significant disability for them. And if you are involved in kind of line managing or rota planning for others, be mindful of the Equality Act and reasonable adjustments, and being as flexible as possible, as we'll talk in more detail about shortly. So support if you are personally affected by long COVID, some general things. If you are not a member of a union already, I strongly recommend that you join one. Personally, having over the past couple of years, having met with kind of senior and executive level people with a number of unions, I am now of the opinion that actually what's most important for you as an individual is getting the right union representative. That matters more than what the kind of overall policy position is of the union. You can have unions who are, actually, most of the unions probably are all saying the right things at a policy level, and releasing supportive press releases and things like that. But actually what matters to you on the ground in your interactions with your employer is the union rep that you have. So I would push for trying to get a union rep who understands the issues that we've spoken about in this presentation, and understands the law. And also, I know that people who are affected by long COVID are often struggling financially. So I would have a conversation with the membership department about what might be possible in terms of membership fees, if you have a reduced income or indeed no income at all. I would join a support group. You may be able to seek some advice on there in terms of what other investigations and things people have asked, how people have managed to obtain, and then you could take that forward to try to, in negotiation with your own doctor. But also, this is a really helpful way of getting kind of social support from other people who understand the illness, which you may not have in your personal life, and also support with dealing with occupational issues, because there's probably going to be other people who have been through similar situations. There is financial hardship support available from certain charities, and certainly when I have met with people from the Royal Medical Benevolent Fund and other charities for doctors, and they were actually surprised by how few people have been in contact with them and how few people have applied for hardship funds. That was a while ago, though, so the situation may have changed the further we get away from special leave having ended. But certainly there was a perception from them that not enough people are approaching them. So please don't, if you are in financial hardship, don't feel too proud. That's what they're there for, and they want to be able to help. And just to be aware as well, the charity, as far as I understand, the charity that's coming forward supporting healthcare heroes, they've applied for charitable status anyway. Unlike other charities like Royal Medical Benevolent Fund and RCN Foundation, who are each for one professional group, supporting healthcare heroes aims to be for everyone who was involved with healthcare work, even people who were missed out by current charities. So, for example, people like porters and kitchen staff who were also exposed in a healthcare environment. And another general point is that I would hope that you are getting support from occupational health, and if not, that you would ask for referrals for them. Some more specific aspects of support. Well, I won't go over this in detail again, but we've spoken about risk at work. You should have you have a right to an individual risk assessment, and if you are affected by long COVID, you already have evidence that you are someone who has significant complications as a result of COVID infection, and it's important that you don't get COVID again, because that could worsen your condition. So your work should take that seriously. I would hope, if you were in agreement with this, that your work would be supportive of you having access to respiratory protective equipment, and remembering that you do have the right to reasonable adjustments under the Equality Act, which I'll explain in the next page, the next slide. And remember, as we said, that you also have the right to remove yourself from an unsafe working environment. So in terms of reasonable adjustments to enable you to return to work or to continue at work, if you have long COVID, you could well be disabled under the definition of the Equality Act. So it's not automatic. It does depend on your individual circumstance, but the definition of disability is that you're disabled under the Equality Act if you have a physical or mental impairment that has a substantial and long-term, so 12 months or more, negative effect on your ability to do normal daily activities. So a high proportion of patients with long COVID will fit with that definition. So you do have the right to have reasonable accommodations introduced for you at work. And accommodations may include having a longer than normal and supported phased return to work, which again, this has changed as a result of special leave ending. So you're probably looking at using leave to accommodate this longer phase return using annual leave, but hopefully an accommodation would include your employer being open to this flexible use of leave. You also, even though you normally only have a legal right to have a union rep or a colleague with you at meetings, a reasonable accommodation may be bringing another advocate with you along to meetings, reducing your hours and different work patterns, equipment at work, like a mobility scooter, which I am aware of some healthcare workers with long COVID using, and access to respiratory protective equipment, as we've said. So actually, what you consider to be reasonable, and really, I mean, what a trade union may consider and know to be reasonable, is not always the opinion of your employer. And so ultimately, if there are difficulties agreeing on reasonable accommodations, you may need to seek union support in terms of workplace grievances and ultimately the possibility of employment tribunal. It is, as far as I am aware, ultimately the decision of an employment tribunal to determine what is considered a reasonable accommodation. However, it certainly is in the best interest of your employer and everyone's best interest, really, to sort the situation out before it gets that far. In terms of dealing with loss of earnings, if you have on sick pay, or you're making a phased return to work, or you are not able to phase up to your previous hours, and so you have a loss of earning, well, firstly, you can apply for benefits. The other option that is technically available is if you have obtained long COVID as a result of NHS work, you would technically be able to apply for the NHS injury allowance, which is a payment made by by NHS employers to eligible staff to top up your pay. But I have to admit, I'm not aware of any healthcare worker with long COVID so far obtaining this, and that the sticking point for this may be that employers have to admit that you caught your disease as a result of work, which, as we know, has not always been forthcoming from employers. So this is just a case example of the kind of negotiation of reasonable accommodations which the HCA have provided. So they were supporting a doctor who was on long-term sick leave with long COVID for 2 years, who eventually undertook a gradual phased return to work. And reasonable accommodations included not only having the standard occupational health review, but their work funding a external health specialist assessment as well, which really makes a lot of sense, and I think is completely reasonable for a workplace to do. We've spoken about how difficult it is to get adequate assessments for healthcare workers who are affected by long COVID, and it's really in the employer's best interest to expedite you getting the medical care you need to get you back to work, even including expediting this through financial means. The HCA also was able to negotiate with this member's employer, who initially were only going to allow them to carry over 5 days annual leave from the 2 years that they had been off. And eventually after negotiations, they were able to carry over 40 days annual leave plus the annual leave entitlement for the year that they returned to work. So clearly this would facilitate a much more supported phased return to work, having that many leave days compared to if he or she was only able to carry forward 5 days. And the last thing, unfortunately, I do have to mention is also to think about support that is available if you aren't able to make it back to work. So if you are aware yourself that your condition is not improving, or if you're being advised to go down the lines of medical retirement, or you're otherwise being pushed out of work, I would do everything you can to take advice on retirement and pensions advice, including hopefully occupational health opinion on this. And I'm no retirement or pensions expert by any manner of means, but I do believe that there are different tiers of medical retirement, and one being that you might be able to work again in the future, but in a different role that's maybe more suited to your health needs. But there's another tier of retirement, which means that you're not able to work at all in any capacity again in the future. So clearly that is a big decision. Will need weighing up of different things, including what pension is available to you, and this is all very difficult with the whole uncertainty of the condition and the prognosis. Also would be eligible to apply for benefits. And I will just mention quickly that if you were in a situation where you have occupationally acquired long COVID, and you're now in a situation where you're either you feel that you're being pushed out, or that you've been sacked from work, I would think it would be appropriate for you to consider seeking legal advice, and hopefully again your union could advise you in this regard. Also, I'm hopeful that there will be other means of support in the future. We've mentioned industrial injuries disablement benefit, and we really need recognition of long COVID and its complications as an occupational illness to facilitate this. The benefit of this industrial injuries disablement benefit is that it is a no-fault payment. So your employer does not need to admit anything, and you also don't need to prove any fault of your employer. If you're eligible for this benefit, you just need to prove that you have the disease and that you caught it at work, or that you can reasonably be agreed that you have it as a result of work. I have put some resources here which I thought would be useful to look at. So one is from ACAS about reasonable adjustments. Another from the Society of Occupational Medicine about long COVID and return to work, what works. It's a position paper, and I think it's a useful one to send to your manager and to your occupational health department, perhaps. There's a World Physiotherapy Briefing paper on safe rehabilitation approaches for people with long COVID, and that is a useful reference to show people, to substantiate that you can't just power through fatigue. You need to pace and manage your symptoms and your activity within a limited window of energy expenditure. And if you are interested, there's also a link to the letter that we wrote and that we sent to the Scottish Government. The letter is open to the public and can be downloaded, and you can use it to send to your own MP, for example, if you want. And that is a useful resource because it has all the evidence that we've spoken about today about the need for clean air and respiratory protective equipment, with all the references as well. And I know I've put the URLs here, but these were all easy for me to find on Google just by more or less Googling the name of what I was looking for, and they came up as the first or second hit. So hopefully that's accessible for everyone. So to summarize what we've spoken about, COVID is spread through airborne transmission of SARS-CoV-2. And so protections from COVID must be effective against an airborne hazard. COVID has had a significant effect on the healthcare workforce, and we've spoken about what actions are being taken already and what changes we need to see. We mentioned some ideas for supporting colleagues who are affected, and then mentioned some ideas about sources of support if you are affected yourself, in terms of risk, reducing risk, reasonable adjustments, and things to think about if you cannot personally continue at work. And I'd like to just conclude just by saying that I hope that everyone does their best to look after themselves, look after yourself in every meaning of the word. I think what the past few years have shown us is that even people and systems and organizations which are meant to protect us don't always do that, and no one is really going to no one's really going to have our back necessarily. So you need to do whatever it takes to be the one to look after yourself, look after your own health and your own well-being, and even if that means going against the grain, I hope you look after yourself.
Wanted to thank Sean for that very informative presentation. It was very interesting, and I hope everyone found it interesting. There will be a recording available on our YouTube channel in the next week or so. So please keep a lookout on that and make sure that you follow all our social media channels as well, just to keep up to date with any other webinars that we will be hosting. Sean, do you have anything else that you'd like to add before we let everyone go?
No, just thank you very much for taking time out of your Wednesday evening to listen, and yeah, hopefully it was helpful.
Yeah, that's great. Thank you very much, Sean, and thank you everyone for attending.
Thank you.
Thank you. Bye.